Good afternoon, everybody. I'm Lee Daly from CARD, the Center for Autism and Related Disabilities at USF. And today we're going to be discussing how to help your patient with ASD or autism spectrum disorder be successful. I don't really have much to disclose, just that what we make at CARD is basically property of USF. All of the things that we do are free of charge at CARD. And it's the Center for Autism and Related Disabilities. We have a CARD center at each part of the state of Florida. Ours covered 14 counties, including Sarasota, all the way up to Polk and Pasco County, all the way down to Lee and Collier County. Today, our goals will be briefly discussing autism, what it is, how it shows up, explore some of the core characteristics, commonly co-occurring conditions, and strategies for enhancing your patient's communication, comfort, and cooperation. So just a brief overview, a little bit of autism. It's not clear what causes autism, but it is pretty clear that it's there from birth. It sometimes does not get diagnosed until much later because there are other things happening as well. So currently, we know that it's not a result of immunizations or parental behaviors as what was thought in the past. It was the refrigerator mothers that was considered to be the reason. It's not that. It does seem to be the perfect storm between genetics, environmental factors, and possibly some other influences, possibly age of parents when they're giving birth. The effects of autism not only affect the brain, although it is considered a neurodevelopmental disorder, it affects the entire body, affects the whole nervous system and the person's functioning. So we'll see a little bit more about that because it's going to really come into play in the hospital. It goes throughout the lifespan, doesn't leave, it changes over time because people adapt and they get to learn skills so they can adapt. It's best to identify people early, that way they can get access to those kinds of things that will help them. So this is just kind of a brief chart that shows the main characteristics that would be necessary to diagnose somebody. So on the left-hand side, you see social impediments and communication difficulties. Those are the main features that people will see right away. Their child is not talking, right? Not looking when you call their name. Not even acting as if you're talking sometimes. They're not really engaging necessarily. And yet some will have that social smile, they will make that eye contact, but then later on you notice that they're having difficulty keeping up with conversation, exchanging reciprocity in conversation, and they may be more aloof. So it just is a span of different abilities and challenges there. You may find people that don't use their voice to talk at all, and they would have to use some other kind of way, either through gestures or through sign language if they could learn it, or through pictures. They sometimes will use pictures as an exchange. And more technology is making that more fluid. The other side of the picture is where you're going to see the person developing as they grow up. You're going to see these things coming into play a little bit more when they can communicate a little bit more. So we see intense focus, the ability to really hone in on something very small in detail or a specific topic. So this could be anything in a child. It could be anything from Disney princesses to sea mollusks to train schedules, and anything that has lots and lots of data, with lots and lots of varieties, like My Little Pony. How many different ponies are there? And they all have cutie marks, right? They have all these different little facets. When you get into the older years, you'll see people having similar kinds of likes, that they like things that can be categorized and things that they can kind of catalog. These intense interests are important to know about if you have a patient on the spectrum, because this is the key to their happy place. This is the place where they go in their mind or in their reality and access those things to help them feel comfortable, remind them of the good times, remind them of good things, and kind of keep themselves centered. So if you can learn about your patient's special interest areas, most people do have one, some people don't. It's not 100% of people, but you usually will find it by looking at what they're wearing. Now, if in their hospital gown, they're not going to show it to you, but they may be, carrying items or have certain things that they watch on TV all the time that are specific to their special interest. They may even have their own iPad or something like that to access that. Sensitivities, we've all probably heard about autism and sensory overload or sensory issues, right? That's probably one of the main things. If you ever watch Rain Man, that's what people used to think autism was. It was just that. And it's so much broader of a spectrum than that. But those sensory sensitivities can really come into play here, because this is a place where there's a lot of unfamiliar stuff. And the sensations that they're going to feel here are unlike things they're going to naturally feel at home, right? The smells, the tastes, the touch, everything about the sounds. So this is going to be important to be thinking about as well when you think about where you work. And then routine and repetition is another area where it's part of the diagnostic criteria. You have to have restricted and repetitive or stereotypic behaviors. Now, stereotypic sounds like you're going to have like a stereotype, right? It's not that, it's not a stereo, but it is usually repeated behaviors that are kind of on both sides of the body. So it might be hand flapping, it could be toe walking, it could be stimming in some way where the hands are involved, twirling the fingers, twirling the hair. This is a sort of thing that people will do for all kinds of reasons. People stim or stimulate for lots of different reasons. We all do it really in some ways. You may chew gum, you may bite the inside of your lip, you may, pick your nails or whatever. You have certain things that you do and you don't even know you're doing it half the time. But it is something that we do as a sort of self-regulation in a way. A person on the spectrum may do a lot of stimming if they're trying to regulate some other experience that they're having, either internally or from the outside, sensory experience, And so that you might be able to see an escalation in stimming behavior or self-stimulatory behaviors when there's something in the environment that's uncomfortable or scary. So that's just something to know about and keep your eye on. Not all stimming is the sign of that. Some stimming is happy stimming and it's like super excited and they might make high-pitched squeals. It can be vocal stimming. It could be singing. It could be phrases repeated over and over. That routine and that repetition part is another important piece of how to help a person feel comfortable here, because what will happen is you have a person who comes to you with all kinds of habits and ritualized routines from their home, whether they're an adult or a child. Even a child can have rituals. They have a certain order in which they do things, the whole getting ready for bed routine, the whole waking up in the morning routine. And they tend to prefer things to be predictable, reliable, and on time. And when things are off, like even have to take a detour on the way to someplace that they normally go, it can really kind of throw the whole mentality off. It can be very upsetting sometimes to see changes happening. And of course, hospitals are a place of constant change. You're not supposed to live here, right? So you're supposed to be moving in and moving out and getting better, right? Most of the time. So that's a challenge for folks. There's different ways to cope with transition. Transition is one of the biggest challenges that we find in the hospital settings, and helping people to kind of move through those transitions is really the goal. Another piece of the autism picture, which isn't really talked about too much in the diagnostic statistical manual, but is a big piece of the thinking process, is that there's certain deficits in the theory of mind. So theory of mind is when you're able to suppose what somebody else might be thinking or feeling in that setting. So you watch a movie and you're seeing a situation where, the mother has to choose between two of her children. One of them is going to get killed by the Nazis and then the other one is going to get saved. And you as a person are trying to put yourself in her shoes and understand what kind of a choice is that to have to make. And you understand why she's crying, and you understand why she's not just like, oh, that one. It's a big emotional thing. But with somebody who has that difficulty of being able to recognize that somebody else has a different thought process than one's own, or feelings than one's own, or intentions than one's own, it's very confusing why people do what they do. It's as if the person with autism may actually have this underlying core belief that, you know what I know. I'm not comfortable, and you know it. I have a bellyache, and you're aware of it. But I haven't said that to you. But because I know it, you therefore know it. And so it doesn't necessarily pan out. You can imagine how crazy making that would make you if you thought everybody knew what you knew, and they're not caring. You know, they're not even paying attention about it. It's like the world is falling apart, and they're just going about their happy business. You know, so it makes folks really, really confused until they learn. And it's a learning process to learn, okay, he does not feel the way you feel. He has a different thought in his head. Central coherence is the ability to take a lot of details and then see the broader idea behind that. So details are great. Details are things that can pick up on, and minutia data, like things you would miss. These are things that they're going to snap into, and like, I saw that you changed your glasses. You know, they'll tell you right away, your hair was on the other side yesterday. Little things like that, but they cannot get the bigger picture easily. So sometimes it has to be really explained how all these little details are going to work together to create wellness, right? So you're getting a shot, and you're taking a pill, and then you have to x-ray, and then you have to do this, and you have to do this exercise, and it's all going to get together to make you go home, right? All of that stuff is going to lead to you getting better, walking and going home. That's the idea, is kind of like telling them, what's the big picture here? There are some physiological challenges with autism. Sensory integration is one of the things that, if you're able to, I can hear a sound behind me. I know there's some kind of engine room or some kind of fan or something in a wall unit behind me, but I'm not going to feel like I can't talk because of that. But for somebody who hears that, and the clicking of the pen that someone else might be doing, and the door slamming down the hall, and possibly a patient calling out for something, it is almost like that is a cacophony, and it's not as if you can just hone in on one thing. So that integration problem becomes really challenging in a hospital, especially with all the beeps and the buzzes and all the sounds that the hospital rooms make. Proprioception is the body in space, the movement of the muscles, the body, knowing how far to get away from the corner as you're turning around the corner, and not to bang your shoulder in the wall or hit your hip on the corner of the table. All that stuff is not necessarily in place, and it sometimes creates problems with you might call a person clumsy if they didn't have great proprioception, right? Because they're always bumping themselves, or maybe tripping on the steps, going up and down the steps. That depth perception can be difficult. Stepping on and off an elevator, seeing the gap in between and having to make that step is the scary thing. Navigating multi-level surfaces can be also challenging. And some have no fear at all. They'll just go for it and not realize, hey, that's a pretty far drop. You don't want to just jump off of that. Vestibular function is the ability to know when you're upright, when you're tilted, and kind of sense that you're kind of equalized. It's like your inner ear almost. And that is another thing that can actually be off, where a person might feel like they're constantly spinning, even though they're laying in the bed, or they're constantly about to fall. You can imagine the anxiety that brings up for a person. Interoception, anybody have an idea what that is? You have 5 senses, right? Ears, eyes, hearing, vision, taste, touch, smell. Did I get them all? We have more than that, right? Someone said sense of humor. I'm like, yeah, that's true. But no, it's more like, what's the sense when you feel nauseous? What's the sense when you have to go to the bathroom, or when you're thirsty? What's that? You have a sense, right? You feel it, but is it touch? Not really. It's interoception. It's the signals from inside your body that tell you something's up, right? So the pressure in your gut when you have to go to the bathroom, or maybe it's gas, or is it a headache, or is it a sinus infection, or is it an earache? Sometimes it's very difficult for a person with ASD to pinpoint what is going on inside my body that's sending me the signal. All I know is it feels awful. And it might just be I have to go to the bathroom, right? A lot of times those sensations may be present, but the person may not know what it means until it's too late. And then they have to rush to get where they need to get. So sometimes that could be a challenge. As people grow up, they may develop a way to strategize around that and help themselves to, manage it better. But sometimes it is really slow going for people to get a grip on what's happening inside their body and understand it to the point where they can actually help themselves. There's a lot of exhaustion in autism because there's a tendency to lack core strength. So sitting up in a bed without a back up, without your back being supported is very difficult for a length of time. Standing for long periods of time can be difficult. Just the body just gets exhausted easily. There just tends to be laxity in the muscles. And then seizures is another physiological difference. About 30% of people on the spectrum have seizures of some sort. And it happens at different phases of their life. Sometimes they have it throughout their life, but sometimes it's just during certain growth phases of their lives, like between 0 and 5, and then again at the 13 to 18-year-old phase, massive growth going on. There's a lot of differences in the brain, the development of the way that the brain connections happen too, the neural connections, kind of like a neural knot, whereas other folks sometimes will actually have neural pruning. After a period of time, you don't need those connections anymore. You've done those developmental phases, so we just the brain actually prunes off different parts of the connections so it can develop new ones. But in the case of people with ASD, they don't necessarily prune anything. They just pack more in there. So it kind of makes things a little bit challenging. So we're seeing somebody here stimming. We talked about stimming briefly before. This is somebody who's doing their stereotypical movements, stereotypical behavior. If I had the sound on, you would hear her. She's actually saying repetitive things as well. And this person is actually enjoying herself watching a show. This is her favorite show. And so, she's doing these movements as a sort of way of, she's probably not even thinking about doing it. It's just her expression of happiness. Sometimes people will do certain behaviors where they scratch or bite themselves. If you had an overwhelming situation that you couldn't tolerate, but you had to endure, you've seen people who, I don't know, hopefully not in real life, but in movies, in the war movies where somebody gets shot and they're like, okay, bite this, I'm going to take the bullet out, and they give the person something to bite down on because they know they're going to have to bear it. And that's what people do sometimes. They will bite themselves because they are having difficulty bearing something. And sometimes they may hit their heads. They may do things that are a little bit more, active than that. It could be a sign that there is a medical situation and a medical condition that's causing them quite a bit of pain, but it hasn't been diagnosed. It might not even be treated yet because they may not always be able to determine that you don't know what's going on for them. Remember that central coherence and theory of mind would state that you already know what's happening with me, so therefore I don't need to tell you much. Which is interesting in the behavioral health unit that you guys are in, because if you're going to do an intake with somebody and you're going to ask them questions about themselves and how you're feeling and what's going on, and kind of try to determine what is causing them to behave in certain ways or to have certain thoughts, maybe they may not offer this information freely. They may not know that you're asking them so that you can provide a treatment plan or something like that. So you might have to actually explain the whole process about what this is about to them. You're here because of this, and we want you to, feel better. And so you can, get some skills and go home. And in order to do that, we need to talk about a few things. And you might have to, go over those things specifically. So just, know that they may not offer that information to you until you pull it out, you ask it. Safety concerns are big in this population because elopement and wandering can really become a life-threatening condition for them. If the person is interested in checking out something they saw on the way into the hospital, they love that fountain or they love that pond that they saw and there was a duck in it, they'd love to go visit that duck. They may just go right in there, walking in, thinking, I'll just go catch the duck or I'll pet the duck, fully clothed, don't check to see, is this illegal, or it's just, this sort of passion that takes over sometimes, and they will just wander away, not knowing that it's actually wandering. They're just on a mission to check it out, right? And they don't know that people are looking for them or that this is a dangerous situation. Quite often that's what will happen. They'll go off and they will get into something fascinating like water, which tends to be one of the big draws because of its sensory beauty. So they'll seek out sources of water to play in, to swim in, to go under, and they don't necessarily know how to get out. It's the #1 cause of accidental death for that population of people on the spectrum. Poisoning is also another one because a lot of people like to explore the world through their senses. You remember, you could have a sensory overload kind of condition, but you can also have a sensory underwhelming condition. And it could be in the same person. Maybe you don't have like a high sensitivity to touch. Touch is, you like the big squeezes, you like the very tight bear hugs, you like the heavy blankets at the dentist when they take your x-rays, that feels great. But you cannot stand the sound of whispers, or the sound of people chewing gum or whatever it is, like there's certain things that just trigger your senses and other things that you seek those sensory things. Some people seek things through their taste and they taste a lot of things that shouldn't be in your mouth. So that can also lead to poisoning. Some people like to chew on stuff too. Chewing is a big sensory feel that a lot of people will go for. And we have like people will actually wear stuff that they can chew. Like it's called jewelry. It'll hang from a lanyard and they can just put it in their mouth and chew that instead of chewing something that would be toxic, like a pen cap. Access to dangerous objects in the home. Some people do have a fascination with guns or knives or sharp things, martial arts weapons. They get into it, that's their special interest, but they may have so much access to it that it's also a challenge because they might have an impulsivity issue as well. So we want to, be thinking about that. That can be a safety concern. And that hypersensitivity and hyposensitivity can also result in overheating, injuries that they're not aware of, broken legs, broken bones, lacerations, all kinds of stuff that because they don't necessarily have that interoception clicking, properly, they're not going to feel it until it's infected or really damaged. So it just depends on the individual. The spectrum is full of people who are exactly opposite. It doesn't necessarily mean that everybody you see is going to be looking the same and acting the same and have the very same issues. This slide is one of the most important ones, I think, to recognize here, because many times it's not talked about. But if you look at the medical and psychiatric conditions of people with ASD, it's staggering. It's absolutely staggering. Not only do we have gastrointestinal stuff, which is pretty prevalent. You'll see that in kids. You'll see that in a lot of people will recognize that. We might start out as a picky eater, maybe labeled as a picky eater, but it turns out that most foods actually make you feel nauseous, or they smell so bad that you can't even get near it. So they pick a few things and they wind up eating what they eat. But is it always nutritious? Not always. But that gastrointestinal, we have, any number of things you could have going on there. GERD, iliac sprue, any number of those kind of conditions could be problematic. And also absorption problems. So mitochondrial problems where they can absorb what they have actually eaten. Their bodies won't break it down. They lack the enzymes to break things down. So it creates all kinds of problems for their intestines. Muscle laxity. The intestines are muscular. They're involuntary, but muscular. If those are not moving along, you're going to get blockages, you're going to get impactions. And so that's also a problem. It's constipation. We see quite a bit of that, pain and constipation. Little kids trying to learn how to use the toilet, and it's a horrifying experience because they're so constipated, just going, it hurts, you know? So sometimes we see a lot of that, and you might get the opposite with some people where everything that they eat just goes right through. Hypertension, diabetes, and obesity are also high on the charts, but the chart toppers, sleeping problems. Sleeping problems is pretty much across the board for people on the spectrum. If they're sleeping well now, chances are they won't sleep well later in their life. It'll be different then. But if they're not sleeping, guess what? Neither is their household, because everybody's worried what's going on when we're sleeping if this person's awake, right? Are they going to get out and get in trouble? Or are they going to do something like get in the pool and drown? Are they going to eat everything in the refrigerator because it's looking good? Are they going to stay up all night and game, and be totally wiped out for the next day? So there's a lot of tension and anxiety around that. About 70% of people, estimates vary, but about 70% of people on the spectrum have a bona fide anxiety disorder, either social anxiety, generalized anxiety. It could be a phobia, could be related to OCD. But yeah, about 70%, it's almost like it's built in to autism. And you can imagine, hey, you're born, you can't really regulate any of the things around you, and the sensations are a bit overwhelming. You can't really communicate what you need. You're not even sure if these people are your people or not. You're kind of lost. You don't know why they're not doing what you want, because they know what you want in your mind, you think. And so anxiety mounts from a very young age, not to mention the eye contact thing that we forgot to talk about. Eye contact is part of communication. You can tell a lot from somebody's eye contact. Those subtle gestures of the facial expressions and the eye contact tell you all kinds of things beyond what they say with their words. But people with autism tend to feel very uncomfortable looking directly into the eyes. There's so much information to absorb in the facial features that actually just listening to the person, it almost becomes impossible to do it when you're looking at all that on the face. So they may not even look at your face to just be able to hear what you're saying and understand it and process what's going on. So a lot of parents will try to help their child learn to look at people's faces because that's what's socially expected, right? They also might want to help their child learn to stop stimulating, stop stimming. That makes you look different. That sets you apart from your peers. We want you to fit in with your friends, don't do that. And so sometimes they will go into behavioral therapies to do those things that will help them be more social. But what it sometimes winds up doing is it relieves them of a coping skill, basically. It relieves them of a strategy to cope. And if they can learn to make face contact, but not have to look right in the eye, sometimes we talk about, just look over the ear here. That's good enough. Close to the face, maybe around here is good. That'll help you, but it won't necessarily trigger all those bad feels that you get when you have to look into the eyes. So that anxiety is a big deal. And depression, after, anxiety wears you down after a while. If you've had anxiety for years, it kind of tears you apart from the inside out in a way. It really wears on your whole system. The cortisol, adrenaline, all of that stuff is just, kind of wearing you out. Depression sets in. And it can set in for a lot of reasons. Sometimes it can set in because you're ostracized, you're bullied, you might be left out of things, you don't really feel a connection to other people. You may look at the world and say, you know what, I don't see any people with autism running the country. Maybe I just don't have a future. Maybe I can't be, this, that, or the other thing that I like to be. And it's not the case. because there are lots of people on the spectrum running lots of things, it's just, but, some people just kind of get in that mindset like, this is it for me, I'm not going to make it. Suicide attempts, look at that, 433% higher than people without autism. That's including veterans, that's including dentists and flight controllers. I mean, that's including all the people, not to say maybe some of those are on the spectrum. I couldn't say they are not all, but that's a staggering amount. And most people who have one comorbid or co-occurring condition mental health wise have more than one. The top three are anxiety, attention deficit disorder, and depression. Those are the top three. We then see what people will call oppositional defiant disorder and OCD, or obsessive compulsive disorder. But I'm going to differ with those opinions, because if you look at what oppositional defiant disorder is about, that is a choice of a person to, or maybe it's a disorder because they don't choose to, but they go in direct opposition to whatever they are told to do, whatever's recommended. It's almost like they can't help themselves. They just won't do it. They don't want to be told what to do. And so sometimes they'll be spiteful about it. They'll, just to spite you or spite themselves, they'll do that thing. I don't see that with people on the autism spectrum. People on the autism spectrum generally don't like being in trouble. They don't like having people feel negatively toward them. They would like it if everybody would just be cool with them. And so they don't go out of their way to do anything to stir the pot up or stir up the situation. In fact, what probably happens is that they can't do what's being asked or told them to do. They can't. They don't know how to say, I don't know how, or can you help me? Or they don't know that it's even a possibility to say, I don't know how to do that, or I can't do all of that. So sometimes it looks like opposition. Sometimes it's a drop to the floor and cry or scream. And that often looks like a tantrum. It's probably not necessarily a tantrum, although some people can tantrum. Tantrums have a real direct goal, and you're a part of it. You have to be there to do it, right, with them. You need to be witnessing the tantrum for it to work. So they will stop it as soon as you walk away. The tantrum's going to stop because there's no audience, right? Your goal, it's a goal-driven activity. You're going to do something, or you're going to take something away that I don't like. I'm going to get something, and then it's going to be over. I'll be happy. But a meltdown, which is what we hear a lot in the world of autism, a meltdown is not a tantrum. A meltdown is literally, I cannot anymore with you. Just it's up to here and I can't do it anymore. I've already had enough. I'm overwhelmed. I want it to stop. And so usually I look at it like a seizure. You wouldn't blame a person for having a seizure. You wouldn't shame them for having a seizure or lecture them later after they had their seizure about why they shouldn't have a seizure and how they're going to avoid it next time. And another way about dealing with seizures is that you would give them plenty of room. Don't crowd around them and try to hold them down. Don't put stuff in their mouth to keep them from biting themselves. Just make sure they have soft cushionings around them, move the crowds away, stop people from gawking if you can help it, and just give them the time to go through the peak of it, and then hopefully it will calm down. It can take a while, but they'll be exhausted afterward, just like a seizure, completely wiped out and probably not remember what they've done or what they've said or what's happened. So we'll get back into that a little bit more. Hopefully you don't see that too often, but it can happen because of those sensory issues, because of the frustrations. So here's some ways that we're going to talk about being proactive. Now, a lot of this you might have heard before, if you've ever taken any of our card trainings. There's going to be stuff here that's going to be familiar. But the first thing is you want to know your patient as much as you can know your patient with ASD before you meet them, before you get a hold of, like a room with them in it. You would like to be able to review their chart, and if they have any background information. I know that Shannon Mersinger has had, and Chris, I think you still probably have a way to gather that information ahead of time. to kind of talk about like, well, what are the things that trigger your senses? What are the things that you have fears about? Do you have any food allergies? Do you prefer to have, you know, spoken word, or do you have to use pictures to communicate? What's your communication mode? You know, all of that's really important because they're coming to you really vulnerable, as everybody is. They're coming to you super vulnerable because this is so far out of the norm of reality for them, and your communication with them, especially through a mask, it's like another planet. You might as well be speaking, you know, Martian, because it's not going to really be received well. Filling out a form ahead of time is not something that people like to do. And if they have a caregiver, they have somebody in their family, a partner, somebody who's coming in with them, a brother or sister, anybody who knows them, you can also seek that information from them, ask them, you know, about this person. What are they like on a typical day? You know, how would I know if they're upset? How do they show when they're upset? How do they show when they're content and happy? You know, what are their favorite things to do? What are their favorite foods? Those are things that you probably should, you know, check into, and then share it. Don't just hold that information to yourself. Share it with everybody on the floor, everybody that works with them, including the people they'll go to, like radiology, you know, phlebotomy, all of that. So if there's family with them, that's important. Now, sometimes you will get the individual on their own. Sometimes they'll come in on their own. They might be homeless. They might be living in a group home and they don't have a person coming in with them to describe everything for them. So you're really going to be, you know, kind of making guesses at that point. If they can communicate verbally, that could help. You can give them, you know, a way to communicate about themselves. But if they're not communicating verbally, that's really going to leave you guessing a lot. Some of the resources that you might want to think about calling in, even if it might not be indicated quite yet, is just getting a bead on who's available for, you know, occupational therapy, speech therapy, physical therapy, mental health consults, behavioral therapy, because chances are if they're going to stay here long enough, they're probably going to need something like that. You know, there are lots of different ways to get people acclimated. When they're coming into a hospital, this is a project that I worked on with a colleague who's now just gotten her doctoral degree. Her name's Chelsea Pierce. And she came up with this idea of developing a model of a room that they would be in. And then building into it places where you could click on things to see what that does. I'm getting a shot in the arm. First, the nurse cleans my arm with alcohol swab. It's cold and it smells strong. Then she makes the shot ready, takes the cap off, gives my arm a little pinch. I think about other things, and the shot goes in. Then she puts a Band-Aid over it. It's all done. If I go back in, I can any of these things I click on in the room sends me to a link about that item so that the person knows, okay, what is all this stuff? There's one for the heart monitor. It makes the beep and it explains why you have to keep those things stuck to your chest and what they're doing. And then that sound is the sound of your heartbeat, you know, through the monitor. Why So that could be done. I mean, if you wanted to take pictures of a couple of different hospital rooms, we can make a configuration like that and make it work for your hospital. It's not a difficult thing to do. Structure and routine is part of autism, the desire for things to be predictable. So if you, as a caregiver, can be as predictable as possible in your interactions with them, that's helpful. So if you show up at 9 o'clock every day or right after breakfast time, that's great, because that is something that they can kind of rely on. It may be the only thing they can rely on every day, you know, that, or that, you know, these two nurses are going to be seeing me, you know, and that, and, you know, if you're going to have to change your shift or you're going to have to take a vacation, you tell the patient, I'm going to be here for today, and then tomorrow we're going to have Cassidy, and Cassidy's going to be here. You might even have, you know, Cassidy come in later on if she's able to say hello. And that way you got a good warm handoff rather than sudden surprise and transition. It helps. If you're going to transport a patient, sometimes it's an emergency. You don't have time to go through all the like niceties about trying to help them through that transition. Sometimes it is just urgent, but other times you can. And that's important to do, is ease them through a transition like that. It's a lot of motion. It's a lot of chaos that goes on. They're not sure if all their stuff has come with them. You know, they may have their own little gadgets and things that they like, and they get really anxious about it. They may even actually like fight you if you're moving them too fast through that transition. If you can help them, I'll show you a couple things you can try saying that will help them to make that transition. Also, having more than one person to deal with at a time is also very challenging. So if you're going to have two people in the room, don't flank the person in the middle and be talking to them, because they don't know what's going on over here. They're looking at you and they're a little freaked out what's going on over here. So they have to keep, you know, and it's really too hard for them to keep switching back and forth. Both of you get on the same side. That way anxiety is going down. They can look at both of you and they can try to process what you're both doing. And if you can avoid having the whole medical team of students come in, avoid that, because that's not the patient you want to have dealing with that. They're not going to do well with that many people coming through. Communication is one of those things that I think I take for granted a lot. Like, I'm pretty casual in the way that I speak, and I might not think about how I'm using words, but what does this, you know, what does this mean when you look at this image here? What does that indicate to you? Kill two birds with one stone. Yeah. So why would we be doing that? That's pretty awful. But you know, we're going to kill two birds with one stone. We're going to videotape this, and we're providing it live at the same time, so that way we can, you know, serve all different kinds of needs. But that something like that will get logged into the brain of a person who doesn't know what that means, and you will forever be associated to bird murder. So don't get caught in that trap. Try to use plain talk, understand that things are taken very literally. So if you say, I'll be back in 5 minutes, and then suddenly someone grabs your arm and says, I need you to do an IV in this infant, you got to come down here. 5 minutes is gone. Now you're not trustworthy anymore. You know, so don't use specific things if you can't do those specific things. Don't say those specific things if you can avoid it. Say more general things that are a little bit more open to interpretation. And then if they ask you for specifics, you can say, you know, I will be back before 3. That's better than 5 minutes and then you fail, right? So try doing that. If you know if the patient can speak, I mean, that's one of the key issues, is being able to communicate. So if you get a patient in and you have not looked at their chart and no one has talked to you about them, we assume what? We assume they're going to talk. We assume they're going to answer our questions. And even if they can use their voice, they may not, because they don't know that we don't know all the things that we're asking them. They don't know who we are and why we're doing this. And they may not even really process what we're asking them if we do it in a way that's too confusing. So find out if they have another way of communicating. And if they don't have that, like if they use a device to communicate, sometimes it's called a touch chat, and they will touch it and it will actually read out what they have selected. Other times it may just be quickly typing. If they don't have that, they are voiceless. They will not be able to communicate with you. So that's really a sad thing, but sometimes they run out of juice, batteries, sometimes they just don't get brought to the hospital by accident, and then they're there without any way to communicate. A lot of times people on the spectrum are far more able to understand and receive information, but far less able to put a cohesive response out to you in a timely manner. That's why it falls apart sometimes with that reciprocity, because they're processing, and you can't tell because there's no little thing like a computer has, you know, there's like the little spinning wheel that's showing, oh, it's thinking. No, that you won't see that. You won't see that at all, sometimes just blank, and you don't know if they've even heard what you've said. So you may have to wait about 10 seconds to think, you know, okay, maybe they didn't get it and I'll try again, same thing. And then if they didn't get that, then maybe I'll rephrase it in another way. I might do that. And just be aware that they tend to be a little bit more visual. So if you're talking about things that are visual, that's great. They can probably build a picture. But if it's more abstract, you're going to have a harder time getting across what you want to say. So 10 seconds or so seems like no problem. I can wait 10 seconds. But if you really look at a 10-second counter, that's not normal for like any conversation. So it feels really awkward, that silence. Get used to the silence. They will love you for it, because I'll get reports from people, they say, I can't keep up with it. That means the demand of the conversation is so overwhelming. I can't keep up with it. I feel like I'm on eggshells because I can't process fast enough, so I just give up. If you can avoid doing things like asking questions that have multiple parts, like a yes and, you know, did you want to go eat? I like pizza. Would you like pizza or muffins? Okay, yes. And then I lost the rest of that. And remember, if that co-occurring ADHD is in there, sometimes they're really going to have a hard time with processing. Find a way for them to express pain. Like, I know you have the thing in the rooms, right? And it's like the smiley face, and then it gets progressively upset. That can be useful. That can be very useful. Find a way. Sometimes they might put a more subjective spin on their pain. I've had somebody tell me that there was a fish in their chest. There's a fish in my chest. And I was like, okay, what is that fish doing? It's out of water. It's flapping. It's on the ground. Okay, now I know. You know, like that's what you're feeling. You're feeling palpitations, you know, that kind of thing. They don't necessarily have the word for it, but they can try to, you know, tell you what it's like or draw what it's like maybe. So we try to pair the visual with what we say, so that when it's all too much to process, they have something to look back on if we use a visual. So if we gave them a way to communicate, that's one way. Give them a way to communicate, like we might say, here's a communication board. You were crying this morning and I didn't know what was wrong. Can you show me on this board? Now this might be too baby-like for some people. They may have, there are older versions of this with adults, you know, who have the same kind of, you know, information. We can help you make these kinds of things, or, you know, deliver them to you. If you need ones for adults, if you need one for people of color, if you need one for women, we have all the different visual versions of this. But it's important, you know, to show what's going on if there's a way. Sometimes they'll actually have you can get it on your phone. You can get you know, something very similar like this on your phone. So it's not impossible to find out, you know, where does it hurt? Point to it, show me. You can also, you know, this is also another way, if somebody's having a difficult time with, maybe they've been abused in some way and they don't know how to go about talking about that. If you have pictures, we have pictures of abuse situations using PECS. This is called the Picture Exchange Communication System, PECS. There are ways that they can do forensics, you know, kind of reports this way to show, you know, this person used their hands on my neck like that, or this person used this device on me, you know, and that way you can gather more data if they're not able to tell you personally what happened. So that's for them to communicate to us. Now we can communicate to them as well. Like sometimes that routine and repetition is important, and it's important to know when something is uncomfortable, when is it going to be over? Because they don't know that they're not moving in here for good. No one probably told them this is temporary, and we forget, like most people figure, oh, everybody knows what hospitals are like. You don't stay at hospitals forever, do you? I mean, mostly no. But for somebody who's not familiar with it, they don't know how long they're here. So showing them the steps to some activity that they're going to do is important, to know there's an end to it. And also showing them what's coming next. Maybe they really love this. In this case, this was for a hospital, which like a receiving facility for Baker Act. They had a gym. They had a basketball court in the gym. It's awesome. This person was really good at basketball. And so that was the main thing that got him through his day, was knowing that he could go to the gym, but he had to do the group therapy first. But, there's a trade-off, right? So we sometimes need to show people these incentivizing things as well. We also might use these little widget things that are helpful to show what's coming next. Like today, you've got this thing, you got to go in the donut on the bed, explaining those things. But this was from another hospital where they had us come in and just take pictures of different people going through the intake process. And it was in the ER. So depending on what they had to go through, it was all on a key ring. And they would just flip through it and they're like, okay, radiology, we're going to radiology now. And they would show all the things that radiology was going to do. They had to put the vest on, and this is where you're going to go, and you're going to lay on that table, and this thing's going to, So it really kind of did that priming that cool little room did at the beginning with the videos. It actually just did it in a low-tech version, kind of explaining a little bit about what it looks like, what it feels like. There's also something called social stories. We can make a social story about coming to the hospital for specific things. So in some cases, it might be about, I'm having an operation. I'm having my appendix out. Or another time it might be that, they have a condition that they have to get used to and they have to start doing medicine for. So maybe they need to learn about diabetes and what all this means. And so what a social narrative does is it primes the person for what's expected in that situation. Let's see if I can get this to play. I'm not going to play the whole thing. I've got my mouse over here. Okay. So in general, it talks about, why do I need to do this anyway? What's the purpose of what I'm doing? What am I supposed to do in this situation? How do other people feel when I do that? How involved is this? And so it talks about, what do I personally have to do? What do other people do? And then what's the final outcome because I did this? It just helps to quell that anxiety again. And sometimes it can teach a skill, so it might teach a skill to a person who doesn't know how to monitor their blood glucose, right? And it would show them, this is why you need to do it. Otherwise, you're going to feel crappy. And if you do it, you're going to be, thriving. You're going to do better, and you're going to be able to get out of the hospital and not have to be here so often. So that's kind of the idea. Just a quick check-in. How y'all doing? Good. Okay, I'm going to keep moving. If you don't have any questions, because I know your time is short and it's getting close to the end. Being flexible, patients really enjoy having some power. It doesn't feel very powerful to be here. People are coming in and getting real intimate with all your different veins and body parts. So, it's very odd and strange, giving them some choices about what they can do, when they can do it. It can be things that you want them to do. It could just be that they choose the order you do it in. And you can also give them the option to stop. If it's not absolutely necessary to do this thing, like you may actually not have to put the compression hose on right now for some reason, like it's just not absolutely necessary, then if they're fighting it, that's okay. We'll do it later. I'll give you time to get ready for that. Give in when you can. But if there's a way and they want to terminate the situation, stop it altogether and opt out, let them opt out if it's at all feasible to do. We do a lot with younger kids and adults. We might do completion first, then reinforcement. So that's a behavioral idea that, like you're going to do something that's hard to do, but then you're going to get something really like you love afterward as a result of doing the hard thing. So sometimes we have to do that visually. And you might want to find out what is the thing that they really love first, because if you're offering them a popsicle and they can't handle that cold, that's no motivation for me. You got to find out what's their special interest. Maybe it's My Little Pony. And I know men in their 30s who love My Little Pony. If you say, I've got somebody who's got a My Little Pony DVD and we can get it in here and we can play it. As soon as you do your spinal tap, you got My Little Pony for the rest of the day. Okay, it's more likely it's going to happen. Again, visual timers are helpful because if you know time's ticking away and it's ending soon, then that's a little bit more tolerable than when is this ever going to end? Same thing like this training, right? So you can see the clock, it's coming down to a close. You want to build trust with the person. So again, use trustworthy language, trustworthy, communication, talking about their special interests in a crisis is important. If they're able to focus on their special interests. Sometimes a crisis can be brought on by too many demands at once, and also undiagnosed medical conditions. Quite often, people on the autism spectrum do not just lose their minds and throw themselves on the floor and scream and cry and tantrum. They don't. They normally just chill, and it's something in the environment that is causing it. Consider having items for distraction. We have these little things for our autism-friendly business partners in the area. So like all the libraries in Sarasota County have these in them because they've all gotten training on autism. These are really helpful. Why? One, they provide something to block some of the sensory input. So a pair of headphones, Harbor Freight, not very expensive, but they cut down about 50% of your sound. Helps with some of that noise in the hospital room. Eye shades, sometimes it's just too bright. Also, those headphones cut down on some of the noisy guests next door, like that come in and out. Just little distractors, they're sensory distractors. Supporting cooperation, sometimes that whole process of not knowing who the communication is for can be really challenging. So if you have two different techs in the room at the same time and a nurse, and they're talking amongst themselves, the patient doesn't know who's being addressed. So if you're really trying to address the patient themselves, use their name at the beginning of the sentence and then deliver the important stuff. Avoid chit chat amongst yourselves if possible until you're out of that room, because if you're chit chatting amongst yourselves, it is adding to the information overload. So in this one, you're telling Samantha, I'm going to use a light and look in your throat for about a minute. So, in about a minute. So I'm telling Samantha ahead of time what I'm going to do. I'm not just going to say, open your mouth and start showering her with light. I'm going to say, in a minute, I'm going to touch your arm and I'm going to feel your pulse. In a minute, I'm going to ask you to open your mouth and say, ah, I'm going to look in your throat. And you would model the action you want her to do. That might get you a little bit further than just demanding that it happen right then and there. Transitions we talked about. You have to transition a patient from one room to another. They've been in their own room now, they're doing better, but they have to move to another room with another person. That's a big challenge. How do you do it? You can't just say, okay, everybody get together, we're going to push the bed down the hall, right? I mean, that can happen, but it doesn't usually. Usually the patient, somehow will get moved. if there's a way to let them know ahead of time, and this one, I don't know if you can read it, but good morning, Donnell. We're going to be moving you to a different room this morning, right? Take a few minutes to say goodbye to this room, right? So they really got to think about, like, okay, I'm going to get all my stuff. And you might want to tell them, we're going to help you get all your stuff. Let's make sure we get it all. And we can focus on that. And then tell them where they're going. You're going to go to a room with a window now. And it's going to be, it's going to have a TV. It's still going to have a bathroom, but it's also going to have another person in there. And there's going to be a big curtain that goes between the two of you. And that, you're going to hear them sometimes, but you won't see them unless you pull that curtain. And you just kind of tell them what to expect about that. Ask, if they need anything. It's okay if you want to wear headphones if they're too noisy or you don't like what they're listening to. If you want to wear headphones when you're listening to the TV, you can do that kind of thing. Whatever accommodations you have available for patients that are roomies. Start with the easy requests, then work toward the difficult ones. And every time a patient does something and complies with what you've asked them, give them plenty of positive feedback. Lots and lots, not good job. No, just real specific feedback. Like, I love the way that you just held still while I took your blood pressure. That really helped, Using distractions, that was the little bag of goodies and fidgets and stuff that help. Again, avoiding the large groups, avoiding chit chat, and avoiding rushing. Try not to rush the patient. Even though you're in a rush, try to just model that calm, serene kind of flow, because if they're gonna rush, through what they're doing, their anxiety is gonna boost up, and that's gonna just cause all kinds of physical and mental problems for them. Just think about where you work and just check in mentally about what is there sensory wise. Are there babies screaming? Are there other patients crying out for help often? Is there sundowners at night? Are there a lot of patients who are, older and wandering sometimes or really confused? Knowing what patients are going to feel and hear and see is going to help you understand a little bit about how to help them manage it. So providing distractions for them during those really challenging times when other patients might be having difficulties is going to help. It's kind of like a contagion thing with babies. Like if one baby starts crying and really unhappy, it almost like sets off a chain event of that. That'll happen too sometimes. People on the spectrum will sometimes pick up on an emotional field around them, and they will sometimes feel, more anxious or more upset around people who are feeling that way. So if you can, just try to model how to calm down, model some strategies for breathing and giving some ways to stim to help themselves self-regulate. And be aware that most people aren't going to sleep well here. So you're going to have that on top of all the other stuff. If you have a patient in a crisis, if they had a way to communicate with you ahead of time, they probably could have helped avoid that, but they may not have that way. So what you can give them once they're in that bad spot is what they can do in that situation. Here are some things that you can do. You can have this pillow. If you want to hit the pillow, if you need, if you're banging your head, here's where you can bang your head. It's not, most people will not do serious damage to their head if they're head banging. Typically, it's not a typical thing that they will wind up actually causing a blister or a hemorrhage or something like that. However, sometimes if it's an undiagnosed medical condition, they will go that one step beyond because it's just so unbearable, and it might actually be a pain related to their head. Although sometimes it's elsewhere and they'll hit their head because that's bringing the attention. Like if your foot hurts, you hit your head. It's a weird thing, but happens. So in the crisis, like a seizure, protect yourself and protect the patient. Protect the patient from, accidentally harming themselves. Reduce the stimuli. So if the lights don't have to be on and it's still light enough to let natural light in the room, turn those overhead lights off. They're buzzing. If you can't hear them, that person probably can. If there's a lot of motion, get the people out of the room. Have one or two staff that are familiar with that patient available, and don't feel like you have to have 50 people. The less people, the less likely the person's going to want to run or bolt or fight, right? There's no one to fight if you leave them, at peace. If you can avoid touching the person, try to avoid touching the person. Our tendency is to try to calm somebody by, like petting them or giving them some kind of physical, touch. It doesn't necessarily work in that state of mind. It actually becomes too much information. So if you're going to speak, try to do so in very short, minimal phrases and positively, like, we're calming down. It's okay. You're okay. Not much more, really. And sometimes they may say things that are going to be triggering to you. They may call you a name. They may have choice words for you. It might be something that they've picked up from some other place and they use it in times of real duress. It may not mean anything. It's not directed. It's not about you. It's just how they are expressing their angst at that moment. So try not to get hooked into a power struggle. At that point, they're just trying to survive. That's what the meltdown is. It's trying to survive the moment. It's not about being defiant and saying no to you. It is really about trying to survive. And then check, could be that they actually have some kind of serious infection. Check the ears, check the teeth, check the toenails. Check for infections in different parts of their body to see, because a lot of times there are. It's also note whether or not they've been given food that is their allergy trigger, because quite often it gets overlooked at mealtime. That's one of the big things, is that all the medications are, check, 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 but then all of a sudden it's like, oh, but they had milk. They love milk, but it makes them really horrible, makes them feel terrible. One thing you want to do also is to try not to be over the patient, like hovering over. Try to be kind of at their same level instead of, top down. And also, I mentioned before, if you have more than one person, try to be on the same side of that person, if possible. Touching them unexpectedly and out of their sight, like coming up behind them and putting a hand on their shoulder and they don't see you coming, is going to set them off. But if they see you coming and you say, I'm going to have to take your hand now, can you give me your hand now? And show them what you want to do. You don't even have to say can, you say give me your hand now. You're making a real demand at that point. When your hand is in mine, then we can go. Then you can go in the hallway, that kind of thing. So try using what you want to see them do rather than what you don't want to see them do. You can't see autism on the outside. Looking across the room, I can't see which one of you is on the spectrum, but you might note certain behaviors. But by that, like you might see the stimming behavior, you might see the lack of eye contact, and you might question, maybe this patient is on the spectrum. I will let you know females. Some females have the classic autism kind of behaviors that you'll see with the lack of eye contact and the very limited speech, but many females, they don't get diagnosed early in life because they have that social smile, they have that eye contact, that sociability that girls are kind of encouraged to have. They're given dolls. Boys are not given human baby, facsimiles to deal with. They're given other kinds of toys. So girls are kind of encouraged to do all that, and they get rewarded and they get feedback for that. Well, that actually winds up masking the autism in a lot of girls. And so they wind up getting diagnosed with a slew of other things and medicated. And then later on in their 18, 20, 30-year-old, they're getting that diagnosis and they're like, well, that makes sense. That's what it was most of the time, you know, but unfortunately you're going to see that, and you're probably going to see that kind of individual in the behavioral unit, possibly because of the polypharmacy, the medications that they've been given for different kinds of other things. Their behaviors have been medicated, but that never found the real source of their behaviors. And it was really processing issues, sensory issues, a bunch of different kind of physiological issues as well. So consider that girls, even though for every one girl that gets diagnosed, boys, there's 4. Okay, it was considered to be a male condition. It's not. There are far more girls now that we're seeing getting diagnosed with that lens of, okay, if we took away those little bits of the snapshots of what classic autism is, and our assessments for autism are normed on boys. The research is going back into the 40s, where boys, were the ones being studied. So we were like, oh, well, girls aren't getting autism. So what's the deal? What is it, a boy thing? Is it a testosterone thing? No, it's just we learned to look at it through a lens, and we didn't see the other side of it, female side of it. So it's going to be there. You'll see it in the next 10 years. We're going to see some changes, I think, in the way it gets diagnosed. That being said, let's just hear from you for a minute. What's one thing that you plan to stop doing? What's one thing that you would keep on doing? And what's one thing or some things that you want to start doing? And if there are any questions, let's have questions. Is there anybody in the behavioral side there? What kinds of things that you're dealing with on a day-to-day basis came up in this training?
Telling them exactly what you plan on doing so they can help around. I did have a patient who's autistic. Whenever I left, she was wanting me to just touch my hair, but I would always have to wear a glove. But for some reason, that gave her.
You're not the first person who said that. There's like rituals of coming and going. And so there's certain little things that saying goodbye to somebody, it gets emotional sometimes. Even if you're just a stranger, it's different for different people. So they have little rituals for doing things like that sometimes. And it's okay. Somebody said she had to touch my hair. She would cry and cry if she couldn't touch my hair. And I was like, well, then let her touch your hair. I mean, it's not that bad of a thing, right?
So one thing I want to say is, one thing we want to start doing, and I'm going to ask this, kind of like the questions are, one, what would be an effective resource to provide maybe for families that have someone in their family that has autism? What would you recommend as an effective resource for us to start providing?
Meaning that the family is not hooked up with resources for the individual? Okay, so one of the things that CARD does is we actually provide, we're like a hub of resources. So we have a huge database populated by information from families and individuals on the autism spectrum about ABA providers, occupational therapists, educational services, lawyers, housing, advocates, dentists who understand autism, where to get a haircut if somebody, is sensory overload. So we have all of that stuff for the 14 counties around the Tampa Bay area. And we have consultants to help the families work more directly with their loved one. So if they're having an issue with a behavior in the home, whether it's early age behavior or high school and job seeking behavior, could be even adult, older adults, there's a lot of people on the spectrum in their 80s that now we're starting to realize, that's what it is. It wasn't schizophrenia all these years. It was autism. What do they need in their nursing home? Well, maybe their nursing home needs to understand what autism is and how it's not the other thing. It's not whatever it was assumed. And so you put a different lens on that, the way that person's trying to live and communicate. So we provide that. We provide the education piece. We provide the direct support to the families. The only things that we don't provide are therapy itself, like the psychotherapy or the ABA or occupational therapy. However, our consultants are from those fields. We're educators, therapists, occupational physical therapists. You name it. Yeah.
And many of their other questions, just a curious thing, and I've looked for patterns over the years dealing with people with autism. Is there a correlation or any data out there that states that the parents of the person that has autism, that there might have been previous substance use, maybe during conception or prior to conception?
It does not show out, actually. There's fetal alcohol syndrome, and there are definitely drug-related syndromes that do show out, but it's not necessarily the same behaviors. It might be more of a learning disability, which is not to say that that can't also co-occur with autism.
Sure.
So, but I think we're getting closer to being able to actually identify genes, for autism, which is different than a mutation or that's happened because of a drug. It's not necessarily going to pass down to the next generation in that case. We're seeing there's like a phenotype that you can usually find somebody within a family. It's maybe not the direct parent, but it could be the uncle or the cousin who's also on the spectrum, and the genetics are there somewhere. It's just what makes that gene turn on. So far, they're not saying it's specific to any kind of medications or drugs, but they have found that it's the higher incidence is in when you're older and you give birth at an older advanced age. That tends to result in more births of children with autism. If you have a child already on the spectrum and you get pregnant and you have another child, the chances of that second child or whatever third child having autism go up by more than 50%. So in order we have a lot of references here if you're interested in more information, but for CARD to get in touch with us, it's pretty easy. These are the counties that we serve. You can contact either myself or Denise, or just call the 813-974-2532. That's our resource office. We also have a website. It's chock full of information that, so useful. I would love to see on your website, and maybe Chris, you can tell me if this is available. Do you have the forms of, the pre-fillable forms for families who are planning on coming into the hospital for something?
Right now, we don't. What we have set up is with David's bid team. When they get admitted and they do their admission profile, if autism is chosen, it triggers a consult to them, to social worker, to military. Somebody from his team goes, and we developed a control questionnaire, an autism behavioral questionnaire, all those things you were talking about. What are your triggers? How do you take your meds? How do you do that?
Yes.
And then that flows into our electronic medical record for everybody to be able to see and to help care for that patient.
That's great. So it's accessible without having to pass a chart. It's in the e-record. Right?
And then his team do have kits, if that is. I have toolkits in my head, and that is not it. Because I was talking about toolkits.
Like a sensory kit.
Sensory kit,
Yeah.
yes. I have toolkits in my head.
Yeah.
Sensory kits, if that's what's
Good.
needed, and they're available to help the staff
Wonderful.
with any questions. And I think one thing what David just said, do you have something we could give the caregivers?
Yeah, I can actually send you. We have a brochure on our website that talks about going to the hospital, but it's really more for for the providers in the hospital. But in there, it also talks about like, don't forget that all the things at home that give this person comfort, probably, you can't take it all, but take the main things that are going to help them function here.
And I think we just want to make sure that caregivers are aware
Yeah,
of you.
yeah, we
and
can
the services.
definitely give you,
um,
we can actually give you the thing that it comes in too. So you could put it, if you want to put it on the wall, it could be, we'll send you as many brochures as you need. We can have a social story about coming into your unit, like, this is what this unit is for. This is what it's about. Here are the things that you're going to work on here. That kind of stuff would be useful. So that while they're waiting and questioning everything in their head, it might be, something they could check into. Is yours like all adults, or is it broken up into different age groups, David?
Well, it's autism with any
Any
patient, whether it's
ADHD.
minor or adult.
Okay, wow. So you mean you have a specific unit just for
not
autism?
necessarily.
Because that's and also, is it a Baker Act receiving unit?
Baker Act.
Is it Baker Act receiving? Do you receive Baker Acts here?
We do.
You
We
do.
do.
Okay.
Basically, it's consults, whether they're a minor or an adult, and they're all over the hospital, obviously. Pediatrics.
Okay.
We'll go and actually consult them,
Mhm.
develop this questionnaire with them and the family, get it in the system.
Okay, that's really wonderful to
So
hear.
we do have a medical unit, but they don't all go there. And as I told the director once, if an orthopedic problem goes to orthopedics, if cardiac goes to cardiac, they're not here because of their autism,
Right,
they're here for that medical issue. So it's pretty hard, we're way too big to put them on one unit.
right. And I can understand why. I mean, that's just so unheard of. But when you think about the Baker Act receiving facilities,
Oh, we can make that.
and it's such a different experience for if it's meant to be in any way protective and therapeutic in some, hopefully therapeutic, but it's not going to be very therapeutic if it's
We do get
how it
patients
usually is.
that cross over in all those areas, like you were saying,
Yeah.
or the mental health. We get the mental health, but we get the medical issues.
So our Baker Act receiving facility, Bayside, here for the part of the hospital that actually, they're very advanced. I was hoping we were gonna have some here today, but they didn't quite make it. They have a sensory room, the whole 9 yards, so they're very
That's
advanced. with
perfect.
autism treatment.
That's why I find when I looked online, I always try to look, a little bit online beforehand, checking out, what is this place about? And I see 4.5-star reviews. You never see a hospital with a 4.5-star review. And I'm like, all right, how many people was that? 30? No, thousands of people on your reviews. And I'm thinking, oh my goodness. And how many times have I done trainings for this?
Yeah.
I
know
mean,
you and
that's-
Denise Burns and stuff.
Yeah.
Yeah.
It shows, it's not just that, but it shows there's an interest in the patient. There's an interest in learning and improving. And it's showing out in the way that people are responding to it. And I think that's wonderful. So I applaud you all.
We're trying, we've made
Yeah.
huge strides.
Yeah.
Even make more strides.
Yeah, with you coming here, Gail, it's gonna help us. That's gonna help us really advance even more. So thank you for this.
I'm so thankful for you all, really. So anything you need, let me know. We're at your service, really. We want to make sure you have what you need so you can be effective. And if you want to try something new, I'm open to it as well, because that's, if you see something out in another hospital, you're like, we should have that, we could help you try to do it, especially if it's related to making a visual or a story or a technology or a film. We have a film student who's working with us. If you wanted to do modeling of different kinds of activities that people do in the hospital, we could get, if you got permission from the hospital to do it, we could come and, do a little sketches of it so that they can go, oh, okay, so that's what that's about.
That's perfect.
Mhm.
I like that, flip card sheet that you said that the different areas that the patients might go. That could be just not just with the autism.
Definitely. And Yeah, so you're asking about the flip card. I'm just saying it again because I'm not sure people can hear you on the recording I'm doing. So there was a description of a sort of a keychain with different cards on it that showed different parts of the hospital and different activities that would occur. So like radiology and things like that. And if you were to take pictures, I wouldn't even have to do it. If somebody would come through and take pictures, you know, of things in isolation or the whole room, you know, that would, and then we can kind of write the cue on the card under, maybe on the back of the card, you know, so that if somebody's like, what do I say? It's right there on the back, you know, just explain what's going on that card. That could really help a person kind of frame, all right, well, it's not that bad. I thought I was going to be, you know, put in an oven or something like that, you know, no, it's just a zip, done, right? So that could be really useful. Thanks for asking about that. And we can do it in Spanish as well. I don't know if you have a lot of Spanish speaking folks. Do you have other languages?
Ukrainian.
Yeah.
Ukrainian? Wow, okay. Awesome. Okay, thank you. Good ideas.
Thank you very much.
You're welcome. Thank you.